Hi everyone, Dr Bharan here, Clinical Director for Shape Primary Care Network and Clinical Lead for Bharani Group Practices. Now, today I want to share with you some exciting work we've been doing in order to reduce the number of people in A&E and really understand why people attend A&E in the first place. Now, historically, nationally, as a primary care team, we've done lots of work to really reduce the number of patients having to attend A&E. We put GPs and various types of clinicians in the A&E department who can help with patients who are more suited towards primary care and triage patients to alternative clinical pathways. We've also done lots of post-admission work in order to understand why people attend A&E and develop alternative clinical pathways for the future. Unfortunately, over time, the things that we've been doing have had a limited effect. We've also made some big assumptions. We've assumed people attend A&E because they can't wait for their GP, or don't want to wait for their GP, or can't contact their GP. We've also assumed that people may attend A&E because they feel that A&E offers a more thorough clinical assessment than perhaps what's on offer in primary care. Now, primary care has evolved through the formation of primary care networks, and it's done this over the course of the last few years, particularly during the pandemic. With the digital capabilities now available in primary care that weren't available for, I'm going to make a bold statement. It has never been easier than today to get access to a primary care clinician. Okay, so my journey started approximately a year or so ago when I was introduced to a powerful population clinical health digital analytics tool called Connected Care. And it's my belief that Connected Care is going to save the NHS. Now, one of the things Connected Care I discovered allowed me to do was to see in real time which of my patients were in the accident emergency department. It was amazing. Sitting in my chair in a GP surgery in clinic, I could log in and see which of my patients from my practice were actually in the A&E department in real time. And when I discovered this, for me, that's when the magic happened. So what did I do once I discovered this? Well, started a pilot. For me, it was really important and interesting to understand why my patients were attending A&E in the first place. Were they attending for clinically appropriate reasons or clinically inappropriate reasons? And if they were clinically inappropriate for accident and emergency, and perhaps could be dealt with and treated by myself in primary care, well, why can't I do that? And why can't I bring them back to the GP surgery if it was safe to do so? And that's exactly what I did over 2.5 weeks. I contacted as many patients as I could from my GP surgery in my GP chair between patients. And those who were unable to pick up the phone when I called, I sent them a text message. The beauty of the text messaging system in primary care is that it allows the patient to contact me and respond to me directly. So when I say, "Dear patient, I understand from our records you're in the A&E department. Is there something I can help you with? Or would you mind telling me the symptoms you're suffering from at the moment?" Well, they're responding back to me, not my receptionist, not my care navigator, and not a generic inbox. Now, all patients who I tried to review were sent a text message showing them and sharing some information around alternative clinical services, which they may not know about, and also some information about how to access primary care, specifically our digital pathways. There were some patients who I was unable to contact, and they were unable to respond to me. So those patients, I looked at their discharge paperwork the next day, and because I knew they were in the accident emergency department, I was specifically looking out the paperwork from these patients. And this allowed me to still make a decision as to whether their attendance was clinically appropriate or inappropriate in the first place. Now, over 2.5 weeks, I reviewed 25 patients. 40% of them I made contact with directly, and I pulled out 16% of patients back into general practice. And I did this when there were clinically inappropriate attendances to A&E and the patient was comfortable and felt safe to come and see me in my GP surgery almost immediately, rather than wait approximately 4 hours and more to be seen by an A&E clinician. I worked out that 60% of my patients had attended A&E for clinically appropriate reasons, and about 28 to 30% of patients were clinically inappropriate, meaning that they could have been seen elsewhere and perhaps not in the accident and emergency department. I also worked out that 8% of the patients in the A&E department were there because my team or primary care teams had referred them to the accident and emergency department. Remember, this was just me, a single GP, doing this between his own patients. I was using an Excel spreadsheet to log my data, which was a bit tiresome and possibly inefficient. I also had some limited information. I knew which of my patients were in the A&E department, but I didn't necessarily know why they were there. And as I did this more often, I started to use other tools like the hospital clinical system. And I worked out that actually, if a patient's already had a CT head being organised or troponin for chest pain, then they're likely to be clinically appropriate. Okay, so after the initial pilot, I was excited. I wanted to share with anyone and everyone who would listen my findings, what I've done, but more importantly, the potential to scale this project up across multiple practices to help multiple patients and perhaps multiple A&E departments. I was invited, and I was fortunate enough and lucky enough to be invited to various clinical forums and meetings to share my findings. The two most notable was the Frimley ICB Population Health Management Conference, and the second, the NHS Southeast Regional Urgent Care Conference. Now at this point, I thought I should mention some key people who were instrumental in driving the project forward. Mark Selman, Chief Information Officer, Frimley ICB. Mark introduced me to connected care, and Mark is a big believer in connected care and using population health management tools to make big positive changes within the NHS. Now Mark, like me, believed in reducing the number of A&E attendances through the use of this technology. And Mark got me in a room with Sam Burrows, Chief Information Officer for Frimley ICB. Sam believed in what we were doing and worked incredibly hard to obtain resources in order to scale this project up across the whole of Slough. And with the ongoing support of Dr. Lalitha Iyer, Medical Director for Frimley ICB, Dr. Jim O'Donnell, Place-Based Clinical Lead for Slough, and Sangeeta Saran, Locality Director for Slough, we managed to scale this project up across the whole of Slough with a makeup of 16 practices with a combined list size of 160,000 registered patients. So now the project was greenlit, I had some work to do. The first thing I did was go back to my initial pilot and reflect upon some of the learnings and things that I'd done. And I used this to create a clinical SOP, a SOP, which could be used by any practice who wanted to participate in the project moving forward. I then worked with our clinical support unit locally to develop an easily importable EMIS template. What this did was allow any practice who wanted to participate to download the template and install it within their EMIS system. The template was great because the clinician who was reviewing the patient within the A&E department could use the template to essentially capture their activity, and it would allow us to evaluate the success of the project moving forward. I then worked with the connected care team to make some changes to the A&E TC notification dashboard. If you remember going back, I could only see my patients who were in the A&E department, and that was great, but I thought it would be a bit more efficient and better if we could have some more information. So now the dashboard not only shows which of my patients are in the A&E department, allowing me to identify them, but it also shows me what their presenting complaint is. So why they're attending A&E. It also shows me their correct mobile number, which is the mobile number they would have given to the A&E department at the time. Often I found when doing the pilot, the patient's mobile number was not up to date on my clinical system. Therefore, having this information made it easier to contact the patient. And lastly, what we have now is each patient stratified or segmented into a clinical criteria, essentially red, yellow, or green. Green patients generally are less complex and may have fewer numbers of long-term conditions, and red patients may be more complex with a lot more social problems or perhaps long-term medical problems, and therefore may well be more suited to secondary care. Now, this information is also available on the A&E dashboard. Armed with a clinical SOP, a new EMIS template, and a new and improved A&E TC notification dashboard on connected care, I approached my fellow 16 practices in Slough in order to scale the project up. So I first introduced it at one of our clinical lead monthly meetings. I went through my initial pilot, some of the findings, and the potential to scale this up. The response was overwhelmingly positive, and almost immediately every practice signed up to participate. Moving forward, I then held a series of training meetings over Teams, so I could showcase the SOP, the EMIS template, the A&E notifications dashboard, and generally go through how to approach reviewing patients within the accident emergency department. Now, there were some practices who needed a bit more time, and therefore I would attend on a one-to-one basis with these practices in order to show them the SOP and the software and the approach to take. I set up a WhatsApp group with the clinical leads from the practices who are actually reviewing the patients in the accident emergency department. These WhatsApp groups and subsequent meetings over Teams were really designed to support each other and share learning from the project. When I look back over the project and the pilots over the last few months, really the thing that comes to mind is the passion, the enthusiasm, the positivity and support that each practice in Slough gave to the project. Now, remember, a lot of the GPs in Slough have been GPs for over 20 years and really dedicated a lifetime to serving their patients. And they did so under a challenging environment, challenging circumstances, in a pressured environment. And working in areas with high complexity and increasing deprivation isn't always easy. But none of my practice colleagues and team leaders were disillusioned with the NHS. Some GP leads had even attempted projects like this in the past. One GP had sat in his car outside the A&E department waiting for his patients to attend to help his secondary care colleagues and reduce the number of his patients attending accident and emergency. Now, it wasn't all smooth sailing for the practices in Slough at all times. Some practices, despite the initial enthusiasm and support, just didn't get the headspace and time to engage as fully as they wanted to do and review all the patients that they would have liked to. And similarly, with winter pressures, staff absences, staff shortages, isolation, some practices had to pause the review process only to pick things up when they stabilised. Similarly, during the festive season, which was incredibly busy and involved Group A strep outbreaks and influenza outbreaks, again, some practices just had to pause during that period and only to pick things up when again things settled down. So where are we right now? Well, as of 16th of January 2023, 13 out of 16 practices across 4 PCNs are actively reviewing their patients in the A&E department in real time. We've managed collectively to review 634 patients. We've worked out that 15% of these patients are attending the A&E department for clinically inappropriate reasons. and over 90% of these patients have been sent an educational text message that helps them understand what to do and where to go if requiring medical assistance. Now, of those patients who are attending for clinically inappropriate reasons, we've managed to pull back and pull out 42% of these patients in real time out of the A&E department back into primary care, therefore reducing the number of patients that the A&E teams have to see and helping our secondary care colleagues. Now, it's early days, but the project so far has shown to be effective, cost-effective, and sustainable. It builds upon and strengthens the rapport between primary care and patients. And it draws upon one of the most magical components, which is underrated in the NHS, and that's the concept of continuity of care, which is the big driver behind this. For those of you who are watching, I encourage you to stay with us as we continue on this journey. Thank you for listening.